my goal is to explain the type of study we do to evaluate neuroendocrine tumors. In radiology with tumor, the goal is always the same. We want to identify the organ of origin. We want to see if the characteristics of the tumor are compatible with the diagnosis. And we want to see the extent of disease. As the treatment will depend on the extent of disease. In particular, is surgery an option for therapy or not will depend on if the disease has expanded beyond the organ of origin. And of course, we use imaging for follow-up and to look at the treatment response. The neuroendocrine tumors are difficult tumors for us because they are extremely variable. And we use two types of technique. We use techniques that are limited to anatomy, where we look at the size, the contours, the appearance of the organs. And for that, we use mostly CT and MRI. But there is another type of technique that are very important, which are based on the identification of molecular markers on the tumoral cells. And this is the basis for scintigraphy and PET, and will be discussed in the next presentation. So I'm going to focus on the anatomic technique. The anatomic technique, again, is CT and MRI. They are both cross-sectional images, which means that we acquire slices of the body in the axial, in the sagittal, and in the coronal plane. Both techniques requires the use of contrast. So you are required to drink contrast, not all the time, but quite often. We sometimes use contrast in the rectum, which means you have an enema when you get a CT of the abdomen and pelvis, and it's required. And we use IV contrast, which is most important. So why do we have to use contrast? I'm going to show you a couple of examples. So I'd like you to focus first on the left side of the screen. This is a CT of the abdomen. This is an axial cut through the body. And what you see in the back, the white stuff, is the spine and the rib. This is the belly. On the left side, there is a large area of grayness, which is fairly homogeneous, with the exception of a few linear areas that are darker. This is the liver, this is the normal liver, and those are the vessels running through the liver. On the other side, there's a smaller organ, which is, it looks very similar, but it's smaller, it's the spleen. And then in the middle, the white stuff here is the stomach, which contains contrast. If I look at the liver more carefully, I can see here a couple of areas that are very dark and round. They are not normal. This is tumor. This is the way it looks. It is not normal anatomy. Now look on the other side. This is the same study. Now the images have been acquired after the injection of contrast, exactly 60 seconds after we started the injection. And what you see is that the whole liver has become brighter. The vessels are much brighter. They are easier to see. The tumor, however, is the same. But the difference between tumor and background is higher than before contrast. And that's one of the reasons we use contrast, because with contrast, we can detect the disease better. Now I'm going to show you another example. So again, this is before contrast. This is the normal liver. Those are the vessels in the liver. And right here, there is a round area that is darker, which doesn't belong there. This is a tumor. The stomach, in this case, is filled with water, so it is not bright. On the right side, this is the same study, but now after the injection of contrast. But unlike the case I showed you earlier, in this one, we acquired the images 25 seconds after the injection. So the liver is a little bit brighter, but not as much. The vessels are not all opacified. The portal vein right here is opacified. The hepatic veins are not. And the tumor is bright. So these two cases are showing you several information. First of all, these two patients have the same type of tumor, neuroendocrine tumors, and yet they do not behave the same after the injection of contrast. What you also see is that over time, depending at the moment we acquire the images, the appearance of the liver and the appearance of the tumor vary. This is a little bit complex, and there is one more element that is going to add complexity to the problem. the tumor, so the liver changes over time. This is before, this is 25 seconds, this is 60 seconds, and this is 90 seconds. The liver is changing in appearance. But this tumor is also changing in appearance. Here, it's best seen on the non-contrast and on the arterial phase. After that, it is more difficult to see, it is more difficult to measure. So what you can imagine is that depending at what time we look, we might not see, or we might judge the size as not being accurate. And that's the reason why for this type of tumor, when we do images, we have to do multiphasic studies, which mean that we scan the liver not only one time, but 4 times. And this case will show you why it is so important. Here, this is the same patient on the same day. The middle image is the one acquired at 25 seconds. This little nodule is tumor. I don't see it before, I don't see it after, which tells me that I have only one shot to find it. In this case, this is a little bit different. This is the same series before, early arterial, portal, and delayed. So over time, the liver changes, and here, the tumor is seen only in the portal phase, not in the bright phase, but later. The problem is we cannot predict which is going to be the best phase to identify the tumor, which is going to be the best phase to measure the tumor. That's why we do 4 times. So the multiphasic technique is very important. It's not specific to neuroendocrine tumor. There are other tumors that behave like that. But unlike, let's say, colon carcinoma, where we don't need this type of technique, we really need it to follow this disease. Besides the characteristics of the tumor, the appearance is going to be affected also by the technique. So when we inject contrast, depending on the speed at which we inject, the results differ. This is the same patient at 3 different dates. On the left, this tumor is very well seen. It's quite bright, and you can see that there are additional small nodules also in the liver that I can see very well. On that day, I see this tumor, I don't see the smaller nodule. And on that day, I see the tumor, I see those nodules, but not as well as the first time. The reason here is the injection rate. If we inject at a lower speed, we don't see very well. That's why when you have those CT, we put big needles. We use big needle because we want to inject at 4 to 5 cc per second to have the higher chance to detect the small lesions. If a patient has cardiac failure, this is going to affect the results also. So when we interpret those scans, we have to take into consideration not only the characteristics of the tumor, the characteristics of the liver in the background, but also the technique. So if I read this study and I am reading this one compared to that one, I could say it's better. Or I could see at the technique that the technique is not as good. So I will say, I don't see those small lesions, probably technical reason. Or if I try to measure a lesion after treatment and I have a study where I see it not so well, I will have a problem to say for sure, is the tumor bigger or smaller? And the way we avoid these problems is by trying to have the best technique and the best bolus and a multiphasic acquisition of the images. Now I'm going to change gear and go to the primary tumor. The principles are going to be the same as for the liver. Extreme variation, issue of size, the smallest, the hardest, issue of enhancement. If the tumor, if we do a technique where we can see the enhancement and capture the best moment, then we have a higher chance of making the diagnosis. The tumor can occur in any organ, most frequently in the GI tract, the pancreas, in the lungs. So I'm going to show you a couple of examples. One in the pancreas. So when the tumor is large, it's okay. This is the pancreas. The normal pancreas looks like that. It's very bubbly. It has a lot of fat in it, interspersed between the lobule of soft tissue. This is also the pancreas, but that's clearly not the same as that. So this tumor is big. It's easy to find. Whatever the technique, we're going to be able to see it. Now, in this case, this is a pancreas also. There is only a vague area that is smudgy, that is a little bit brighter. quite hard to diagnose for sure. If I look at the earlier phase, this is more obvious. So in the pancreas, again, we are running into the same issue. The brighter, for hypervascular tumor that have a lot of vessels, the brighter, the best is going to be for us to detect the lesion. Another example of small lesion, this is less than a centimeter, very tiny. This bolus is excellent, very bright, we can see them. In the small bowel, it can be also extremely challenging. So in this example, the small bowel are those tubes that are relatively dark, filled with water. The tumor are this tiny bright nodule that I have marked with arrows, so very, very tiny. So to detect that, we have to have a good technique again, because a few seconds before, a few seconds after, the enhancement will be gone. And as you were told, the tumor in the small bowel might be very small and difficult to find, but generally, we can identify the general area of the disease by identifying the nodes that are in the mesentery, along those vessels that feed the segment of bowel where the primary tumor is identified. So that is what we use to, when the tumors are very small, the landmark that we use is to look for nodes in the mesentery so that we know in which segment of bowel to look. And these are the coronal images on the same study with the liver and the vessels and the nodes right here. So our goal is to tell the surgeons how many vessels are involved and how high the disease extends on the mesentery, so that they have an idea of what will be the extent of resection for treatment. So the third element I wanted to touch on is the response to treatment. So when we evaluate the scan for response, we look primarily at the size. The size is the main element we use to say if it's better or smaller. But as you can imagine, our interpretation is affected also by the technique. If we see the tumor very well, or if you don't see them very well, the level of confidence that I'm going to have to say it's better or worse is going to be variable. In this example, this is the scan before treatment. This is the scan, this is the follow-up. So I'm comparing this study with this one, and the measurements generally are going to be either 1 diameter or 2 diameters. It doesn't really matter that much. But if I eyeball, it looks a little bit bigger. The measurement might be changed by a few millimeters. Sometimes quite often, especially in low-grade tumor, the changes from one scan to the next are very small. So if the report says there is a change of a few millimeters, the significance is relatively low. But in this case, if I look at this smaller lesion right here, and I compare with the scan before, this is clearly bigger. This is very tiny, and this is larger. So here I'm sure there is, so in this case, I might say most of the disease is not changed significantly, but there are areas that are progressing. The other parameter that we use is the enhancement. So this is the tumor that I'm using as a target. Not easy to see, but clearly there is an area of brightness. After treatment, the size is the same, but the vessels are gone, so it looks dark. And that's an indication that there is response, because it's an indication that the amount of vessels in that tumor is decreased. The next staging, the enhancement has reappeared, and this is an indication of progression. For all of this scan, of course, I have to keep in mind the technical element. Is it related to technique, or is it really a change? So in conclusion, the tumors are very challenging because sometimes of their small size, which makes them very difficult to detect. Challenging because they behave differently. There is not a single pattern, extreme variation. To protect ourselves against missing disease and misinterpretation, we use this multiphasic technique that I just presented to you. The choice of the technique, I showed you only CT, but MRI is providing the same type of information, and the choice of the technique depends On the patient, like for example, if the liver has become fatty after chemotherapy, MR is going to be better than CT. If someone is allergic to iodine, then obviously CT cannot be used and MRI should be used. And it also depends on the local expertise and on the local habits. So, but essentially, the information are very similar with CT or MR. Okay, gallium scan, I will leave that for the next speaker. Interventional radiology, approach to liver metastasis. Well, that is not my field, but I think Dr. Chen has answered this question. We can do embolization, we can do RFA. So all these techniques are for, the goal is in all cases to destroy the tumor, but it's limited to by the size, by the extent of disease. So that's, again, this is not my territory. And I think we talked about it earlier. The next question, can you explain to me measurements on the scan report, why they are bigger, but the doctor says my tumor is not growing? Okay. I think I'm hoping you can understand a little bit why sometimes the radiology reports are not conclusive. There are so many variations, and I think that when there is a conflict between the radiology report and what your clinician tells you, you need to ask your clinician what are the elements on which he bases his opinion. If the radiology report says progression, but the progression is only by a few millimeters, this is not significant. So I could say the tumor is larger in my conclusion by a few millimeters. But if I look at the whole story, if I look at many other scans, I'm going to see that variation of a few millimeters might have occurred many times, and that overall the extent of disease is the same. So the discrepancy generally occur when the changes in size are very small. And with low-grade tumor, you might see zero change for a year, 2 years. It's very, very slow. So that's mostly, I think, the situation when you have discrepancy, right? I mean, what do you think?
Yeah, no, I think we certainly see this discrepancy between millimeters of creep and the
Yeah, so it depends a little bit on the radiologist being, I would say maybe a little bit obsessive, because if we measure a tumor and it's 2 to 3 millimeters different, and I measure it a second time, I will find 1 millimeter different. Yeah, there is an incertitude on the scale. So changes by 50%, everybody's going to agree. Changes by a few millimeters, this is when you have discrepancies. Okay, the next. Why do some AMD use MR and some do CT? So that's what I was saying. I think CT for me is the simple, the easy test, which is not appropriate when the liver is fatty or somebody who has a very low-grade tumor and is very young. I don't think radiation is an issue, and I don't really want to get there. But for somebody young, then sure, I don't think you should do CT. I think we should do MR. So the decisions are really case by case. I think most of the time we use CT, but if you have a low-grade tumor with very little change over time, MR is fine. As long as we know what are the limitations of both tests, the decision is really based on expertise and patient characteristics. Is there a limit to the number of MR a patient can have? I don't think so. I don't think there is a problem with the number of MR you can have. Instead of taking 4 pictures, could there be a way to either take an X-ray video or screen? No. No, we cannot do that. The technique that we are using today is such that we don't have that option. And I'm not sure that would be an advantage. I don't think it would change the radiation dose. I don't think it would be very helpful. How can you ensure that the staff administering the contrast is doing the appropriate? Okay, so that question is the way we do. So the injection, the nurse is asked to put the biggest needle they can for the reason I explained earlier, which is we want a high rate of injection. The scanning time, this is protocol. So the technologists that do those CT or those MR know exactly what to do. And there is not much room for error. I mean, there error occur, but I think it's very rare. But what happens is that, as I hope I was able to convey, this is a dynamic process. So your heart rate is going to play a game. The injection rate is going to play a game. I mean, we have multiple parameters that we cannot control 100%. So from one day to the next, the images may be a little bit different, but those are parameters that we cannot control completely. And what I see from year to year, I see the same thing. I mean, there are variation, there will be variation. It's just impossible otherwise. Scanning hardware for multiple scan. The scanning hardware is the protocol. We try to have consistency. We have most of the scanners we have are the same brand. We have protocol that reproduce similar images. So in general, there should not be much effect from that. Multiple radiologists read them. Yes, but again, there is no way around that. We cannot be reading the same patient all the time. I think we follow the same principle, and it's reproducible. But I think that when a question occurs, you should ask. You know, if the report seems that if you don't understand the report or it seems that there is a conflict with the preceding one, I think it's totally appropriate to ask why and get a justification. It's going to be, most of the time, a technique issue. Again, a technique issue which may be the heart rate, which may be the fact that on that day the needle we inserted was not big enough because the vein was not accessible. Changes that occur all the time, and we have to adjust to.